Hello, I'm Rose Higgins, the CEO of HealthMyne. We're a Madison, Wisconsin-based applied radiomics company that's focused in oncology. Dr. Robert Gillies from the Moffitt Cancer Center rather famously said a number of years ago that images are more than pictures, they're data. And that really is the essence of radiomics, which is the emerging science of actually extracting data from medical images. When you think about the fact that over 90% of all healthcare data comes from medical images, this obviously is a vast array of untapped data resource that we're able now, through radiomic techniques, have the ability to bring forward. And the value, obviously, of that data is multiple. First and foremost, it can be used in a predictive capacity to help us understand which patients can benefit from particular therapies. It's also prognostic in allowing us to understand what are the likely outcomes from a particular approach. And ultimately, it's personalized in that this data is very specific to the individual. What radiomic data captures is actual tumor biology data. So we have the ability to look directly at what's occurring and really understand it in a very detailed way. If you think about the fact that every cancer patient is on a journey that is accompanied by imaging, so every image is a step along the way in terms of the progress of that person's eventual return to recovery. And so as we think about that beginning at early identification, screening or early identification and diagnosis, there's also phases in which treatment planning is occurring, as well as assessment of whether or not a therapeutic option is actually performing as expected, and then ongoing evaluation of that over the course of that therapy. And so all along the way, images are being captured, and within those images reside this radiomic data, which we now have the ability to extract and bring forward. In addition to being able to get to this data, we're improving the quality of the data that's available. So first and foremost, if you think about what you see here on the left-hand side of your screen, this is a CT scan of the lungs. And typically when it's read by a radiologist, you'll get something that suggests what is the long and the short measurement of a particular lesion or area of interest that they're focusing in on. It'll be accompanied by something that's really rather qualitative in nature, so describing it as abnormal or suspicious. What we want to do is get to a more quantitative understanding of what's being read. And so with that, the radiologist or the imaging scientist can actually still capture that long and short, but can compare those images across time and look below that first level of data and really understand, perhaps in a more appropriate and precise way, what's actually occurring. So if you look, for example, at this long and short in March versus November, there's a difference, but it's a relatively nominal difference, and so it might not raise an alarm bell. But when you look at the radiomic data relevant to volume or density or texture, you begin to see a really different picture emerge, and that's the point. We want to be able to go in there, capture that data, and bring that new quantitative understanding to the fore. We currently extract about 1,600 radiomic features, which in turn become imaging biomarkers from the lesions that we're actually mapping in our software. So I want to talk for just a minute about radiomic use cases, so ways in which you can apply this type of capability. So within our core platform, which is a cloud-based solution, we do image segmentation and contouring and annotation. We then do this radiomic feature extraction. That then becomes what's used for biomarker identification. And we can also provide services that help translate the value of those radiomics. But again, in keeping with that cancer journey, there's all these various ways in which we can bring that radiomic information to you. And so I want to talk about a couple of those specific use cases in the context of different clients that we're working with today. One of the areas we think is most exciting is around clinical trial design. So with this type of new data, you can actually be armed with information that you wouldn't have had previously about stratifying different arms of the trials, who should be in which arm of a trial, having information now that you could use to adapt your trial during the course of that particular trial, so you know that your endpoints are actually material and something that then can be, of course, highly valuable to you and not require you to go back and repeat a trial or redo a trial. So you have the ability through adaptive trial design to inform those decisions and create a really, frankly, very vital and very responsive strategy for how you manage your trials overall. This is an example of working with a large pharmaceutical company that has our tools that help curate the imaging pipeline and mine radiomic data, and that's in service of getting to therapy response information. So really understanding that radiomic data and those images helps them understand what's really transpiring as they begin to assess within their trials model if a therapy is actually progressing as expected. We work with another organization, Encore Medical, which delivers real-world data and analytics solutions. And in this instance, we're partnering that imaging data with the other kinds of data that Encore is able to bring to the table, like clinical data. And that then gives you a much more fulsome understanding of the total picture of what's transpiring with that particular patient, and building a new data asset here that can be materially important to those organizations interested in that kind of real-world evidence, particularly within the biopharma and life science arenas. So we're going to transition now to a demo or a therapy response capability, and I'm going to turn you over to the capable hands of one of our customer success managers. Thank you very much.
Thanks, Rose. My name is Katie Dickerson. I work on the customer success team here at HealthMyne, and I'm going to be giving a brief demo of our therapy response module. So right here, we're looking at our HealthMyne viewer, and you'll notice that it's set up particularly to facilitate a therapy response read, in particular RESIST. So right now we're looking at the third time point, time point 2, for this patient, and we're looking at the previous reads here. And over on the left, we've got this sidebar that's going to walk us through what we need to do for this patient. So to start with, I'm going to take you to target 1. And looking here, we've been tracking this lesion, and I'm just going to use our RPM, or Radiomic Precision Metrics tool, to segment it. And the idea behind RPM is that it's built on a very familiar long-axis drag, but compared to your standard digital calipers where you're just getting a measurement, you'll see as I do this that it's generating a preview of the lesion contour as I do it. And from that preview, we're able to generate a full 3D model of that lesion. So I'm going to go ahead and accept that. And you'll notice here that we were able to calculate the long and short axes. And because we've got that full 3D model of the lesion, we're not relying on me and my expertise to know exactly what angle and what slice those axes are, the biggest on. We're able to, find that mathematically. And so this really helps to drive consistency and accuracy in your read. So obviously RESIST has its own rules built in, looking at just the long and short, but one of the benefits that comes from using HealthMyne is that you've got, because it's built on this 3D lesion, we've got all of our radiomics and intelligence behind that. So even outside of that, we're still generating hundreds and hundreds of metrics to give you more insight into what those lesions are doing. So, basic things like volume, as well as growth metrics and texture metrics, and all sorts of things in the background that you can then, take that data and use in the other functions and analyses. So, for example, looking here, we've got the basic long and short, the volume. We've got an analysis of the solid density volume of those lesions here, and then those growth metrics as well. Obviously being NA here, either because it is the baseline, or for doubling time because it's been shrinking. So taking a look at those. So going back then to our RESIST read, I'm going to jump ahead. I've pre-segmented these other lesions for us. One thing I will point out is that we do have the capability to track non-target lesions as well, which of course, the benefit of using RPM for those target lesions is that it's quantitative and not just qualitative like a lot of radiology reads are. But obviously these non-target lesions are intended to be qualitative, and so we can support that as well. You don't have to volumetrically segment absolutely everything in the read. So I will identify that here, track it, and then we can go on. So I'm going to review the RESIST instructions here before I continue. I know a lot of you probably have a smartphone app maybe that you use while you're reading to make sure that you're following all of the RESIST criteria. Maybe I've seen posters up in the reading room, we have that all here, nice and easy to access while you're reading, but also because HealthMyne has actually ingested all of these rules. We're totally aware of what resist is supposed to be, and so we've got that all built in as well, so that we can help to assist you read with live decision support. So for example, if you're familiar with resist, or if you caught it while I was scrolling there, you'll know that target lesions have to be tracked since baseline, and that they have to be a certain size in order to count as target lesions. So I'm going to break the rules here. We're on 5.2, but I'm going to tell it that I'm segmenting a target lesion. And you'll see here in a moment that it's going to yell at me. It's going to tell me that I'm breaking the rules, that I'm doing something wrong. And it's going to give me this warning sign here. And the nice thing about these warnings is that they're very clear. It tells me exactly what the problem is and exactly what I need to do to fix it. So for starters, you're only allowed to have 2 target lesions per organ. I've already got 2 in the lung, so I've caused a problem there by drawing another. Target 4 is new, but it's marked as target, so I need to, either mark it as new or take it out of the protocol. And then, of course, it is too small. So I'm going to go ahead and just take that out. I'm just going to call it a finding. So I'll still get to track it, but it's not going to be part of the resist protocol. All right. So now that we've done all of our segmentations, I'm going to take us into our worksheet. And got that pulled up here. So, oops. All right, here we go. All right, so this worksheet is generated automatically based on all of that data that we were getting from the read just before. So you'll see we've got obviously all of our measurements pulled in with references as well to the images that they came from. We've calculated all of the relevant things that needed to be calculated, all of the percent changes, the summing the diameters, etc. And we've given a suggested response for the lesions in that, based on the rules and how those are supposed to be evaluated. You'll see we've got another warning sign here. Obviously, again, that non-target lesion section is qualitative, and so it's prompting me to let it know what I think here. I'm just going to call that non-CR, non-PD. And then down here, we're going to see that we've also, based on all of that data, we've got a suggested response. So based on the rules and all of the measurements of our lesions, HealthMyne has determined that this is stable disease. I do, of course, have the option to override that. We always want to make sure that the reader is in ultimate control. So if I were to do that here, I could say, no, I disagree. I think it's complete response. We're going to give me another warning there to let me know, hey, you may have changed this by accident. According to the rules, that's not what it should be. And if I really disagree, I can leave a comment about why I've done that and say that, again, just making sure that all of your reports are following all of the criteria rules to help reduce some of that overhead of people having to double check, making sure that you cross the T's and dotted the I's, and that if you have made any of those changes, that you've documented reasoning for it, just making sure that everybody's on the same page. So I'm going to put that back. I'll agree with HealthMyne's assessment. We've got obviously some nice interactive graphs here built in as well, and key images are calculated or captured automatically as well. So it's a nice full report, all generated automatically based on your read. And then here, I'm going to go ahead and publish this as final. I'm done. And when I do that, based on how I've got the trial set up, it's going to send a notification either in HealthMyne or by email to whoever I've decided needs to be notified of those final reports. We can also facilitate a number of different workflows. Those can be sent to as captured images back to the PACS, et cetera, other systems downstream. So, all right, so next we're going to be looking at a Lugano read. So now we're looking at a Lugano read. In this situation, we're looking at a baseline scan. So if you're familiar with Lugano, you know that aside from measuring your lesions, there are a number of other tasks that you need to do in order to complete the criteria. And so HealthMyne has a nice guideline here to make it really easy for you to follow the list and make sure that you do all of those tasks. So to start with, I'm going to place my SUV reference in the liver. I'm going to put that right here and accept. And then, of course, we need one in the aorta as well. So I will do that. Put that here. Okay, and you'll notice as I do that, that my tasks will get checked off. I'm going to come back to this spleen at the end, but first I'm going to measure some target lesions. So I can click this button here to tell it that that's what I'm about to do. Looking at my my NIP, of course, I'm going to, there are obviously many things that you might want to be following here, but for the sake of the demo, I'm just going to be looking at these lymph nodes here. So I'm going to go ahead and scroll up. And one nice thing to note is that HealthMyne generates this. So if you don't get it from the scanner, we're able to generate that as well. And this fusion is generated by HealthMyne as well. I'm going to zoom in, and I'm going to segment this lesion right here. And one thing you'll note, so as I go through, I'm using our Radiomic Precision Metrics, or RPM tool, to create this contour, and it's built again on the concept of a long axis drag. But you'll notice that traditionally, obviously, the long axis gives you a nice 2D measurement. But as I do it here, it's giving me a preview of what the contour of that lesion looks like. So I'm going to go ahead and hit accept, and with that data, it's going to create a full 3D model of that lymph node. And I'm going to go ahead and accept that as well. And you'll notice the SUV value has been automatically, the peak SUV within that lesion has been identified automatically for me. I just have to accept it. And we'll go with that for now. But okay. So these warnings here, make sure that we follow all the protocol rules. I'll show you in a minute how that helps. But here, for example, it's let me know that I don't have a location assigned to this particular lesion. And obviously that location is important for making sure that we're following all of the protocol rules. As far as which organs the lesions are part of, how many lesions per organ. So now that I've done that, that warning will go away. If you ever need to double check what the protocol rules are, we do have a nice button here to take you directly to a summary of those rules, explaining, selection criteria, evaluation criteria. But as much as possible, we've built these into the system so that you shouldn't have to do too much, referencing back and forth. One example you saw just now, I was able to know about the location issue. One other thing I could potentially do, if you're familiar, you know that lesions have to be a certain size in order to qualify as target lesions. So I'm gonna cheat a little bit. I'm gonna tell the system that I'm segmenting a target lesion here. Obviously that's nothing and it's quite small. So when that happens, it's going to give me a warning and let me know that I've broken the rules. And what I love about this is that it's very clear. It tells you exactly what the problem is and what you need to do in order to fix it. It's not measurable, but I marked it as a target. So what I need to do is to change the designation or take it out. So what I'm going to do, I'm just going to go ahead and delete that lesion because it's not anything. So, all right. And then lastly, before we jump into our worksheet, we need to measure the spleen. So I'm going to jump into an NPR view here, zoom out a little bit. And I'm going to find the spleen right there. And drop that over there. And you'll see my measurement has popped up here. I can make adjustments if I need to, but all right. So now we've checked all of our lists. We could identify more target lesions, but for the sake of time, I'm not going to. So I'm just going to show our worksheet here. And just like in the viewer, it's going to let me know if there are things that I need to do or change. But as we scroll through here, you'll notice that as much as possible, this worksheet, this has already been built for us. So all of our relevant metrics for our lesion have been pulled in. It's identified the lymph node as pathologic based on the size. It's got our spleen measurement here. The bone marrow assessment is not something that we can do automatically yet. So it's going to prompt me to let me know that I need to do that. I can fill that out here and that warning will go away. It's given us our SUV measurements. It's given us our evaluation based on those measurements. So I do always have the opportunity to override that if I disagree. And if I do that, it's just going to ask me for an override justification. So you know, we're trying to enforce that you're following all the rules, but if we always also want to make sure that the reader is in ultimate control. So if you need to make any of those changes, we just want to make sure that you're documenting and giving reasoning for what you're doing so that everybody stays on the same page. Reduce the amount of time that people have to spend double checking everything or doing rereads to account for things like that. So obviously this is our baseline read, so the suggested response is going to be baseline. These charts get more interesting as you add time points, but we'll graph those metrics that are relevant to the study. And then we do also capture key images automatically, include those in the report as well. So once I'm done here, I can go down and publish the report, confirm, and that takes care of my portion. Now that I've completed the report, HealthMyne will send a notification to whoever I've got set up to receive those, either within HealthMyne itself or by email. We can also send those reports to a number of downstream systems as well, wherever you need them to go. And that's our therapy response workflow.
Thanks, Katie. That was great. So now if you have any particular comments or questions, we welcome them, but I just hope that we've been able to provide for you a glimpse into the capabilities that our solution provides in managing key evaluation criteria, RECIST, iRECIST, PERSIST, Lugana, and so forth, a very adaptable tool, also configurable to meet your needs based on any other kind of trial design elements that you would like to incorporate. So with that, I would welcome, if you have any comments or questions, please visit us at our website, www.healthmyne.com, or through the Congress website as well. Thank you so much.